Hello, and thank you for joining us for our CE program for veterinary dentistry to learn all about cone beam CT imaging for veterinarians. It's an up and coming product. It's being used by more and more veterinarians, both dentists and surgeons, orthopedic specialists, as well as general practitioners. And it's just something that there's a lot of questions out there in the field for what it is, how it works, what it does, how does it differ from medical CT, and we're going to learn all about that tonight. We have three presenters who are going to be speaking tonight. First one will be Steve O'Neill. That's myself. I am the North American Sales Manager for Plan Med, the manufacturer of a cone beam CT system called the Verity Vet. We're going to learn a little bit about, again, the technical details and the specifics of cone beam CT and what it is and how it works. Then Dr. Mary Bulow from Animal Dentistry and Oral Surgery will be presenting a few cases and talking about her use of cone beam CT on a daily basis in her practice. Excuse me. And then Dr. John Lewis will also be doing the same. So it's going to be a great evening of information and conversation. If you have any questions on anything, you can put them into the chat function of our GoToMeeting, and we will answer those at the end. But we appreciate you coming, and thank you very much for joining us. So let's talk about a little bit of housekeeping first of all. The CE for this program has been approved for those attendees that heard this program live. CE is not available after the fact, and that continuing education credits were provided by Silo Academy, which is Dr. John Lewis's organization. The agenda tonight, we've kind of already done it. I'll be starting basics of cone beam CT. I'll be presenting some research on clinical efficacy and the differences between cone beam CT and intraoral imaging, which is really the standard and what's been used by dentists, both human dentists and veterinary dentists since the beginning of time, so to speak, and just talk about what those differences are and the things that you can see. And then Dr. Buell will make some clinical case presentations, followed by Dr. Lewis. Then we can use the Q&A function after the fact. Can do some live Q&A as well as use the chat function in your GoToMeeting hookup to be able to send chat questions, and we'll present them to Dr. Bulow and to Dr. Lewis. And the CE certificate for those attending live will be sent to all attendees, and that will come from the Silo Academy. So it's important to understand that cone beam CT is really becoming quickly the standard of care in human dentistry. It wasn't like that always. It's been around since about 2000. It's when it was first introduced. But I spent 10 years, actually 13 years, selling intraoral and extraoral imaging to human dentists before I joined Plan Med. And our sales mix has pretty much flip-flopped in the last about 30 months or so from what was about 70% 2D and 30% 3D, where today it's about 80-20 on the other side. It's about 80% three-dimensional imaging that are now being bought by human dentists. And it basically comes down to they can see more, they can do more, they can take better care of their patients when they're able to see things three-dimensionally. This is an image that you're going to see more of tonight because it is one of the cases. I'm taking her thunder away a little bit from Dr. Bulow, but this is just the perfect example. This is a brachiocephalic dog that came in to her practice. An intraoral image was taken. The dog was exhibiting some drainage from his eye. And it just goes, in taking a 2D image and the subsequent 3D image that just shows clearly what the problem is when you can't see it from the two-dimensional side, but it's very apparent three-dimensionally what the problem is. The 2D versus the 3D just clearly shows more, gave Dr. Bulow a much more certain diagnosis and a more confident treatment planning procedure, which is exactly what happens when you're taking these three-dimensional images, which then leads to a higher patient acceptance of your treatment plan. So let's talk about the terms a little bit, just so everybody is understanding when we're talking the information and talking about things, so everybody understands what it is that we're doing. Cone beam computed tomography is what CBCT stands for. It can also be called cone beam, can also be called 3D CT. There's a variety of terms that are used to describe the technology. But computed tomography, tomography being a slice or a sliced image, and it's computed. That means it's rendered, it's calculated, it is reconstructed. That's what cone beam computed tomography means. The DICOM data set, digital imaging and communications in medicine, that is just the way that the data is stored on the computer, but that is the DICOM data set, or the image volume. The voxel is the resolution of the image. That's the definition per se of what you can do, and that is basically a voxel is a 3D pixel. Everybody knows what a pixel is and has seen their digital image become pixelated when you expand it and you enlarge it. Well, a voxel is that three-dimensional pixel, the three-dimensional side of things. Your field of view, FOV, that is the cone beam field of view. Cone beam delivers an image that is cylindrical in nature. It has a diameter and it has a height, and that's primarily measured in centimeters, but that is what FOV stands for, is field of view. Stitching is the ability to combine two or more image sets to form a larger field of view. It's not a bad thing. It gives better and more capabilities for your images. Stitching is something that's done all the time by different manufacturers. It should not be looked at in a negative way. Reconstruction is the computer program that creates the 3D image. A 3D image is comprised of a number of individual two-dimensional slices. As the image goes around the patient, or as the tube head goes around the patient, I should say, it's taking a number of individual images, and depending upon the voxel size or the resolution and the field of view will determine how many individual two-dimensional images it will take. The reconstruction is what the computer does. That is the computed part of computed tomography, where it takes all of those individual two-dimensional slices and reconstructs it into your three-dimensional image. MPR stands for multi-planar reconstruction software. That's the power of cone beam imaging. That's what allows you to see things in the three planes, axial, sagittal, and coronal, as well as the wow factor, which is that three-dimensional reconstruction that everybody has seen in three-dimensional imaging, that allows you to take that three-dimensional representation and spin it all around and turn it around and look at it from any direction that you want. But that is the MPR software that does that. And again, we already talked about the three planes of axis of a 3D imaging, of a 3D image. The 3D rendering is that 3D model interpretation of the multi-planes of the 3D X-rays. And then you have the slices, which is the ability to slice through the various planes of the image and look at it from different slices going through that image from any of those planes of axis. So this is just a very general representation of what 3D can do for you. This is a typical image. This is your front view. So you could think of this as your two-dimensional intraoral image when you put it into your patient's mouth. And in this particular instance, we've got a photograph, or we've got a drawing of a building with what appears to be a chimney of sorts and a tree. But looking at it from this one plane, or this one view, the front view, we have no idea what might be hiding behind or around this image. Well, by taking a second view, a second plane per se, That now tells us, well, indeed, it is a chimney, but it's on a separate building. That's pretty significant. We now know something more than we did from just the front view. We can also see the representation or the relativity of where that tree is positioned in relation to that house. And then, of course, the third view, or the three-dimensional view, going from the top, gives us the ability to see everything in all three planes. And we see that we have a sidewalk over here, but now we see that the sidewalk is curved. And it gives us a representative example of where these things are. And that is the advantage of three-dimensional imaging. And if you look at this and kind of relate them to the multi-planes, you've got your coronal view, your sagittal view, and your axial view. And that is essentially what 3D imaging does. A little bit about the differences between medical CT or fan beam CT and cone beam CT. The X-ray source in medical CT or fan beam with multiple detectors that you see is constantly turned on and is rotating constantly while the motorized table is moving the patient through that fan beam. And the relative speed of that motorized table moving in relation to the rotation speed of the X-ray source and the detectors is what gives the slice thickness or the detail of that medical CT image. Since your X-ray source is on all the time, you have a very high radiation dose to the patient when you're talking medical CT, and you have different type of voxel. We'll talk about that in a moment, but that is the difference between, or that is the way that medical CT works. Cone beam CT is not a fan beam. It is a cone-shaped X-ray source. The patient remains stable in the middle, and the X-ray source and the detector panel rotate around the patient on a C-arm. Most of you, or many of you, are likely familiar with the panoramic imaging in your dentist office, your human dentist office. Those are usually, or oftentimes today, your cone beam imaging is a dual function of your panoramic two-dimensional imaging. So you've got the X-ray source and the flat panel detector that are spinning around the patient, and the tube head is actually pulsing on and off very rapidly as it's going around and taking a series of images that you can see down here, two-dimensional images. Once that's done, the volume is first captured with these two-dimensional projections, and those projections are commonly referred to as frames. But as you can see, depending upon which direction or what rotation you are, it's going to result in images of your object of interest that have different orientations to them. Again, depending upon your field of view and your resolution, the size of the voxel. Typically, cone beam CTs, the image volume are made up somewhere between 400 and 600 frames. 400 and 600 individual X-rays make up that full cone beam volume. Once those are taken, those 400 to 600, let's just say for the purposes of our conversation that there's 500 individual slices, those 500 images are now reconstructed. There's 500 frames are now reconstructed to create the 3D volume. And once the computer knows the relativity of the location of your object of interest, it can build your voxels. It can stack your voxels. Think of it like building and constructing something out of Lego blocks. It's very similar to that, if you can kind of visualize that. The voxel sizes can be changed, varying in our particular machine anywhere from 200 to 400 microns in size, or micrometers. Remember that a micron, there are 1,000 microns in a millimeter. So it's a very, very small measurement. The human hair is somewhere between 40 and 70 microns. That gives you a little bit of relativity of understanding of what this is. And the 3D images store all the information slice by slice, which allows the computer to understand where everything is. So medical CT, and I'm gonna mess up the pronunciation of this word, I'm sorry, anisotropic voxel versus an isotropic voxel. Medical CT results usually in this anisotropic voxel, which is longer in the z-axis, whereas the isotropic voxel, which comes out of cone beam, has equal sides all the way around. It results in better clarity and better detail, which is usually what is needed for dentistry, is the isotropic voxel. Most offices that have access to medical CT that deliver an anisotropic voxel discover that it's fine for taking images of bones and joints and things of that nature from a I'm losing my word, I apologize, but for the detail that you need for tooth level and those sorts of endodontic type procedures, the anisotropic voxel just doesn't give the detail. But here's the example of the difference in a larger voxel versus a smaller voxel. In that same relativity, a lower resolution versus a higher resolution. Remember, the smaller the voxel, the higher the resolution. And this is just two devices or two things made out of. The larger one would be the Duplo style of Lego block versus the standard Lego block. You can just see the detail that you're able to get. So there's a lot of different things that are different between traditional 2D radiography, fan beam medical CT, and cone beam CT, and these are just some of them. The image capture in 2D radiography, of course, is individual images. The fan beam has constant radiation on, and the cone beam, you've got pulsed radiation. This is what results in different beam shapes and certainly different image doses when you compare the different methodologies of capturing radiographs. When we talk about patient dose, where a single radiograph from a two-dimensional standpoint can be low, typically you're using multiple images. For instance, a full mouth series has can oftentimes have a higher complete series radiation dose than a single cone beam CT that captures the full jaw. So you have to take that with that understanding. But you have just a variety of difference in these various methods. Again, if there are any of these slides that you would like to have, you can certainly contact me via email, which will be at the end of the presentation. I'd be happy to send you these slides. So let's talk for a moment about the research. Unfortunately, there hasn't been a lot of research done on the veterinarian side of the equation. Most of the research on cone beam CT, or the comparison of cone beam CT versus 2D radiography, has been done on the human side. So we're going to present a few of those cases here this evening on both the vet side and the human side, talking about those differences in clinical efficacy between these. Here's one that was done from the veterinary side, appeared in the American Journal of Veterinary Research in January 2018, evaluation of diagnostic yield of dental radiography and cone beam tomography for the ID of anatomic landmarks, okay? And the conclusion was cone beam methods were better suited than dental radiography for these sorts of things. And again, if you want to take these down, you can go and look these abstracts up, and you can look up these images or these studies for yourself. Here's another one about the diagnostic yield of dental radiography, meaning two-dimensional intraoral radiography, as compared to cone beam for looking at dentavelar lesions in cats. And again, in 2019, in that same Frontiers in Veterinary Science, done at UC Davis, which incidentally, UC Davis has done a tremendous amount of research on cone beam CT, the diagnostic yield for cone beam was significantly higher than for dental radiography. And here's another one that's probably, they both came out at about the same time, February of 2019, right? February of 2019. This was probably the same series of images, but they were just looking at anatomic structures versus the idea of lesions. But again, same kind of thing. It can obtain significantly more information for identifying those structures in cats in this particular case. Now, here are some of the human things, some of the human studies. This one appeared in Dental Maxillofacial Radiology in April of 2014 about changing the treatment plan. We have intraoral images, we have cone beam images. In what percentage of time did it change the treatment plan? In this particular case, 53% of the time, having the cone beam data and the cone beam image to look at changed the treatment plan versus when all the study had was the intraoral image. So of course, the conclusion, CBCT has a significant impact on the decision efficacy in endodontics. Here's another one, use of cone beam computed tomography in endodontics. This is a position statement put out in 2015 by the AOMR, which is the American Association of Oral Maxillofacial Radiologists, and the American Association of Endodontists. And again, intraoral resulted in an accurate diagnosis 36 to 40% of the time, whereas cone beam CT resulted in an accurate diagnosis up to 83% of the time. Boiled all down, cone beam altered the treatment plan 56 to 62% of the cases. Again, more information, more certain information, better treatment planning. Sensitivity of this one. Sensitivity means, did the modality see what was actually there? And this study, which was published in the Journal of, or the International Endodontic Journal, showed that the sensitivity for intraoral in these human subjects was 27 to 38%. Now think about that for a moment. What that means is, on the low end of this, 3 out of 4 intraoral images did not show what was truly there. 3 out of 4. That's astounding to me. Sensitivity for cone beam CT was 89%. Huge difference. Here's another one. This detection of periapical bone defects in human jaws. Okay. Now, the patient didn't get into the study until after they had taken an image with cone beam CT and found a lesion. So that's why the sensitivity for cone beam was 100%. But then they took those patients, or they took those jaws, they put a sensor in the mouth, knowing exactly where to put it, knowing there was an endodontic lesion there. And the sensitivity for the intraoral sensor was 25%. Again, 3 out of 4 failed to see what they knew was there. And this was all the way back in 2009. So this is getting to be an aged study at now, 10 or 11 years old. And cone beam CT image capability and imaging quality is, for me, I've been selling cone beam CT since 2009. And the difference in image quality between what was done 11 years ago and what was today is night and day. So let's talk about the clinical workflow and staff productivity, just in comparing and replacing an FMX with cone beam CT. Taking an FMX, which I certainly can't do, is a difficult process and requires a trained staff from about a 1 to 2 day certification course to be even able to take an FMX on a patient in veterinary medicine. It takes 15 to 30 minutes to do so. You might have some people that can do it more quickly than that. I've often observed doctors taking the x-rays in the office because it is very technique specific. And we've already seen the studies that show that it's less diagnostic than a cone beam CT, and it's especially difficult on your brachycephalic breeds in dogs. I can teach any one of your staff members how to take a cone beam CT in less than 2 hours. Done. Takes about 3 minutes, and that includes the setup, the positioning, the capture, and the reconstruction of the image, maybe 4. The actual image where you're pushing the button, exposing the patient, is 15 or 20 seconds at the most. But that 3 minutes is the entire setup, getting the computer ready, positioning the patient properly, the capture of the image, and then the reconstruction of that image afterwards. Remember, taking the individual 400 or 500 images and reconstructing them into our 3D representation. It does require an effort by the veterinarian and staff members to understand the 3D software and how to work with the 3D software to be able to get to the spot 3-dimensionally that you want to see, that is your area of interest. But again, within a couple of hours of practice with the software, you can certainly be competent with it and understand where you need to go and how to get there. And cone beam CT absolutely generates added revenue for the practice. Dr. Bulow and Dr. Lewis will speak later about the financials of cone beam CT and what they're doing, but most of our users are getting anywhere from $150 to $350. Some are even getting upwards of $500 to $600 for their cone beam CT when they're taking those images. But again, if you've got that clinical efficacy of 25% sensitivity versus 85 to 100% sensitivity for cone beam, doesn't it make sense to price your cone beam image at a level that your patients are not going to balk at taking the cone beam imaging, the cone beam image? You're going to see more, you're going to find more, and you're going to be able to present cases more confidently. And that's why you come to work every day. You don't come to work to press the button on an X-ray machine. You come to work to do the dentistry that pressing the button on the X-ray machine actually finds. So the goal is to be able to take the X-rays that are going to yield the most diagnostic information. And our research that we presented tonight and that the doctors will present later will show that cone beam just shows that much more information. It's very simple to position the animals in the machine. Has a bore size, that's the size of the area that because the tube head in the center will go around the patient. It can be used for both dentistry, of course, and for orthopedic imaging to a certain degree. You're obviously not going to fit a large breed dog in the smaller bore. Some cone beam systems have larger bores and are able to fit larger dogs into them. The one that we manufacture has a bore size of about 40 centimeters. That you can fit 35 centimeters, something like that you can fit into. It's great for imaging exotics, including Inca the jaguar, which was just a great case that actually Dr. Lewis worked on. We don't have time to go into it tonight, but this is the 3-dimensional multiplanar software. In this upper left corner in this software is your coronal view, front to back. Your sagittal is right to left. Your axial is up and down. And then you've got your 3-dimensional representation, the 3-dimensional rendering down here in the lower right-hand corner. And if anyone would like to see how the 3D software works, again, please feel free to call me, send me an email. I'd be happy to set up a online demonstration and show you how the software works and how easily it works and how easy it is to browse. Again, Planet Med is the manufacturer of the Verity, which is a very versatile cone beam CT imaging platform for veterinary medicine. That's about all I had on that portion, or on this portion of the presentation. And now we'll turn it over to Dr. Mary Bulow, where she will present some cases and talk about the use of her system and the way that she uses cone beam CT in her practice each and every day. Thanks for joining us.
Oh. I brought Pinky into my practice, I think about a year ago, and it's definitely changed the way I practice. And that's what this talk really is about. I'm just pretty much going to go through some cases, show you guys some cool things that we've done with our CT, and kind of explain to you how I've incorporated it into my practice. But it's funny because I feel like when people started to use dental x-ray, probably, oh my gosh, how did we ever do dentistry without dental x-ray? And I'm getting to be one of those people with my cone beam. It's how do I do dentistry without cone beam? So I call my cone beam Pinky. I'll talk about that in a second. But yeah, we added Pinky about a year ago. We have two surgery rooms. One is in the downstairs part of the building that we're in, and one of our surgery rooms is upstairs. So Pinky is right here. In the surgery room, this is our surgery table. If we follow the direction this way, we just roll the surgery table back, and this is our operating suite as well back here, one of them. So anyway, it's kind of nice. We can just use this table, roll them in, and back them up. So, obviously adding Pinky into our practice is, it's a big financial commitment. And so I wanted to make sure that we advertised it appropriately, let people know that we have it. I am the only dentist in my region that has one. So we definitely like to advertise that. So I thought it would be fun to just introduce Pinky on our website as Meet Pinky. It's in the About Us menu on our website. I think it probably draws more people in than just saying, cone beam, talking about cone beam CT. I don't know if anybody's likely to click on that, but I think they're more likely to click on Meet Pinky, and certainly following the statistics of my website, that is a little bit more popular. So that's how I kind of introduced it. I also sent out a lot of, introductions to my referring vets through MailChimp and whatnot. But anyway, when you click on Meet Pinky, these are just kind of 3 screenshots of my website about Pinky. I have a really good web designer that I work with, and he came up with this idea of just kind of putting these little notches on different things that you can click on to just kind of learn about the anesthesia machine, the place where the head goes, and the anesthesia. So that's how you can kind of navigate through if you're a client and you want to learn more about the machine. And obviously we have some written words about it too. But I thought that was kind of just a fun way to introduce our machine and bring some traffic to the website. So anyhow, this Lexi is kind of just one of my most interesting cases. I'm going to talk a little bit more after Lexi about kind of the difference between X-ray and cone beam and how I've really harnessed the capabilities of cone beam in that regard. Lexi was just really cool, and I feel like talking about her. So Lexi is a middle-aged lab mix. She was adopted about 5 years ago. She has an unknown past prior to her rescue. It was somewhere in the rural South that she was adopted. I don't know where, but she was a pretty happy dog. She had this scar on her face that the owner really didn't know much about, didn't really care much about. And he described her as a pretty happy dog, but she never really played with toys. She never really chewed on bones, which, we've all rescued dogs probably. So some dogs just don't do those things. So it was never really a big thing, but he did notice that, she had these chronic quote unquote sinus infection. So I'm guessing, nasal discharge, sneezing, things of that nature. And she always had some tearing discharge from just her right eye. So that's kind of her history. Now, at some point, these quote unquote sinus infections became so bad that her vet took just a 2D x-ray on her of her skull. And that's what he found. So, years of sinus infections, that's what we took, and that's what he found is an arrowhead lodged in her skull. Very shocking, very sad. And so the owner was obviously very interested in getting this taken care of ASAP. And we lucked out because the vet called us before he called surgery. And we said, we are very excited and happy to take this case. So Lexi came on over to our hospital, and I put this video in. I don't know how fast it's going to play, but one of the first things I noticed when we were looking at Lexi is that every time she tried to open her mouth at all, she would lift her right leg up and kind of wince. So here, I'll play this and see if you guys can see it. So it was just kind of this pronounced, you know, like grimace that she would do. And the owner did say, yeah, she has been doing that more. And I looked at her and just, you know, knowing that she had this arrow, my heart just absolutely broke for her. So the first thing we did is, you know, all we have is a 2D X-ray. So we gave her some Dextome and Torb, and we got her into the cone beam to find out where this arrow is, what is, you know, how are we going to approach this? You know, this was definitely a case where we wanted to get our imaging and give ourselves some time before we went into surgery. So this is where the cone beam is so fun, and I didn't include all of the images that we looked at and all the slices we did and, you know, all the manipulations we did. But just having a really good 3D, and of course I think a regular CT would give you this too, but gosh, it's nice to just kind of throw her in and get this done in a minute with some Dextome and Torb in my hospital setting. So anyhow, this arrow had amazingly managed to escape many vital things and pretty much went very much midline and then right under the right eye, right under the orbit. So it did not damage any of the dentition. And I'm going to forget what kind of arrow it is. If there's hunters that want to, you know, chime in, you can. But we had a lot of hunters. We have a lot of hunters in our area. So we were able to find out what type of arrow it was. My colleague and I, Dr. Raleigh, he's the one that did the surgery with me. But we, you know, we did all this research into all, you know, these things to find out how are we going to get this arrow out and what's the best approach. So I just kind of put this slide together, just showing the different images, as Steve was talking about, you know, the coronal, the axial, the sagittal. This is a panoramic view, and just kind of getting an idea with all these different views of exactly where this arrow went, what structures might it be stuck in, and what were we kind of dealing with as far as getting it out. So you know, we decided to make a midline approach right down, you know, where basically the entry wound was, and you could feel that on her exam too. And then what we did was we used our piezo surgical unit. This lecture is not about that, so I'm not really going to go into it. But this was a really nice tool to have to be able to. We had to really enlarge our bony window to be able to get a good view of what was going on and make room for the arrow to come out. And this unit was very nice in allowing us to do that without any significant bleeding. So, you know, basically this was just 2 hours of, you know, very gentle manipulation, sterile Q-tips, kind of, you know, getting tissue out of the way, you know, manipulating the arrowhead, you know, trying to move it, but it was really lodged in there. So it took a lot of convincing to get this thing out. I put just a small video
so
of just
missing,
kind of this, you know, us working to get this out.
It's fine. I'm hung up eventually. I've got to take a.
So just, you know, just a lot of manipulation. So finally we were able to pull the arrowhead out. There was one blade that was stuck in a piece of bone, and again with the CT we knew where that was. We were able to remove more bone and get a better look at it, but that was that huge arrowhead. This poor baby had this in her head, and this sweet girl woke up, and you know, she's definitely not a fan of being in a hospital setting, and she was walking within an hour of surgery trying to leave, but she recovered fairly amazingly. So just kind of an interesting use for the cone beam. It was just so nice to have it and get that 3D imaging, you know, the second she walked into our building with just a little bit of sedation. Here's Lexi about 3 weeks after surgery in her house, and even better is the owner sent us a couple pictures, and she clearly is eating a lot better because she has packed on, I think that her last recheck was at least 10 or 15 pounds more, 15 pounds more, but she's chewing now. You know, she had never ever chewed a bone before, and I think he's overindulging her, and she plays with balls, you know, and it's kind of heartwarming to see. So it's kind of broken up for you guys, but. A happy dog playing with a ball, nothing better than that. And here she is chewing on a bone, you know, being a very normal, happy Labrador. So she did post-operatively, she did have increased pressures in her right eye that was managed by an ophthalmologist, and she did well with that. She's doing well. So anyhow, no residual issues. She does not have full range of motion in her mouth. I'm guessing just scar tissue, so they're doing some physical therapy with her, but she's doing great. So anyhow, that was just kind of a fun case to share. But now I'm going to talk a little bit more about what we use, you know, our cone beam for day to day. And as Steve talked about, I think brachycephalics, it's a no-brainer, and we've gotten to the point that we pretty much will only use cone beam for brachycephalics now, because we have been shown so many times how much is going on that we can't see with between x-rays and an exam. Just an example, this is my own cat that I rescued that, you know, I mean, she is like, she ran into a wall really hard and it is like indented with her little nose there. So this is a normal cat, and just looking at Squash, that's her name, Squash, her CT looking straight down, you know, there's no way to evaluate with that with an x-ray. There's no, you know, there's no 2D here. Here's the regular cat. So this is Fabio. He's, you know, this is the case that Steve showed you a little bit of the x-rays of. He's a 1-year-old pug. And he was our first cone beam patient where I thought, oh my gosh, thank goodness we have this technology. It's amazing. So this was a while ago. He came into our ER facility with acute facial swelling and obviously, as you can see, copious pustular discharge from his left eye. They saw him on a Saturday. Nobody really thought tooth. Somebody put him on antibiotics, and he came back on a Monday, and I happened to be walking through the ER, and I saw him, and I said, oh my goodness, I think that might be a tooth. And they were, you know, they were a little bit back and forth, but, you know, they said, well, maybe, you know, and so they did transfer him to us so that we could do a CT. They let us have him, and that was good. So we anesthetized him. And, you know, the first thing we saw was the broken 4th premolar there. But I needed to be pretty convinced that all this discharge was from a tooth and nothing else. And here's our x-ray. Steve showed you this x-ray, and I don't know if anybody disagrees. When we have our chat at the end, we can talk about it, but I did not see anything on this x-ray that convinced me that much swelling and that much pustular discharge was from a tooth. So again, this is a case where I was just really happy to have this technology, and you know, we put him in the cone beam, and believe it or not, it actually was not the 4th premolar, it was the 1st molar on the left-hand side that was causing this abscess. And you know, it's clear as day on these coronal images. This is the 3D reconstruction, but you know, there was absolutely no question in any of our minds that was the cause of the abscess. And these, you know, this is, I wanted to bring this up too. These are always nice to have when you're doing surgery on these dogs, because you know, I'll run them through the cone beam, and when I'm doing surgery, I know exactly how close, you know, the apices of these roots are to different structures. In the mandible of these dogs, you can see where the canal is, and that helps me when I break roots. I mean, you know, it happens. So it's got multiple benefits for that reason. But Fabio was a great case, and I thought we could all see the happy picture of him. This was only 4 days post-operatively. This little man, he was only a year old. I mean, this dog healed like a monster, and came back so cute. So Fabio did great. But a really good case of, you know, after Fabio, we really started to think, gosh, I think we need to consider using our cone beam for most of our brachycephalics, and that's what we do. This is my own dog. You know, Fabio was endodontic disease, and I think that's one of cone beam's strength is endo. And you know, I'm very picky about my endo candidates as far as root canal, and I think that once we start doing more cone beams, we're going to get a better idea of how successful endo is in veterinary medicine, but also what cases maybe are good and not so good candidates for root canal therapy. I admittedly do not use cone beam at this point for my rechecks, but I certainly am thinking about starting. anyhow, outside of the endo discussion, this is my own dog Noodles. I did her routine yearly cleaning and x-rays the other day. I only do cone beam on my own dogs because it's just easier and a lot faster than doing x-rays. So this was her 3D view, looked normal, but within 30 seconds of going through her sagittal views here, I noticed she had, bone loss around the apex of her first molar. It was not broken, it's a healthy tooth, so I don't know why this happened. She likes to make a lot of disease in her mouth, but yeah, and now here's the x-ray. I think it's pretty clear on the x-ray too, to be completely honest, but just kind of, I wanted to show you guys what endo looks like on the cone beam. And here she is actually another tooth of hers. And, I obviously see some furcation, but this is the apex on the coronal view. And again, I think it's so clear to me on cone beam, whereas on x-rays, it can be questionable. So I wanted to put those examples in there just to kind of show how we look at endodontic disease in our practice. This is actually one today that I threw in here really quick, kind of just showing 2D versus 3D. This is an oronasal fistula, and this is also something that I'm starting to use more and more cone beam for, because it just gives you such, look at your 2D view. Obviously, this dog has a lot of bone loss. Of course, we can see that pretty clearly. And, it sounds like John's going to go through taking you through a cone beam on the program, because it's hard with these screenshots to show you exactly how, we can kind of go through every slice and really evaluate. But I have an axial image here just kind of showing this, the bone loss. And I didn't appreciate how bad it was around the incisors. To be honest, they probe normally. But once I looked at it, you can see this bone loss, you can see the apex of the third incisor. It just gives you a much better idea of how big of a pattern of bone loss it is with oronasal fistulas. I have actually, based on a cone beam, gone with a membrane and kind of changed my idea of what I want to do as far as the care of one. So anyhow, I saw that today. I thought it was an interesting just kind of comparison of 2D versus 3D. And my last little subject here, and then I'll give it over to John, but Steve talked about using this for joints, for bones. And one of our technicians has a shepherd, a German shepherd, who had elbow disease. And to save her money, I said, oh, well, if the surgeon will accept it, I'll do a cone beam of the elbow. And the surgeon said, great, that's fine. And I mean, she talks about that cone beam of the elbow to this day. She said she has never seen such a clear joint in her life. She was able to diagnose the dog, treat the dog. And so, for those who do orthopedics or who have surgeons in their practice, I think on a revenue standpoint, I'm in a little bit of a weird situation where I own my practice. I operate in a building with multiple other practices, but they have their own CT unit, so they don't take me up on the use of mine. But they were very impressed with how good the images were in general. But one way I use it is with knees and teeth syndrome. I have seen 3 of these cases in the past year, and this case, this little guy Finn right here, I'm embarrassed to say I saw him a year or 2 ago, just as a consult. His vet sent him because he had retained baby teeth, and they had resorptive lesions on them, and I didn't really think much of it. I scheduled a procedure, but things happened in their life, they couldn't make it in. Long story short, he ended up actually with the neurologist about 6 months later for an MRI. He was having issues with his back legs, and they did an MRI, they did taps, they diagnosed him with feline or femoral neuropathy, I think is what they diagnosed him with. So anyhow, he comes back to me after all this about 6 months later, and they said, okay, well, we're finally here to get his teeth done. And I looked at him and I thought, oh gosh, he has knees and teeth probably. And I told them, and they said, why didn't you say that last year? And I said, well, I don't think I realized it last time. So anyway, one of the first things I did is a cone beam of him. And you can see his retained baby teeth, very typical of knees and teeth, but I put his knees in right away too, because I wanted to kind of prove to myself that that's what it was. And certainly we have a little piece of patella up here, down here. And so, it was a really, really quick 1 minute image of his knees and kind of proved my diagnosis right away. So just kind of an interesting side use of the machine. And obviously those cases are very interesting. So anyhow, oops, sorry, I went past. So, you know, just as my final slide here, when do we use the cone beam? I already explained we have 2 surgery rooms. Pinky is on our 2nd floor. We use it every single day. We charge, we are not very aggressive about charging for it at this point. I think we might become so, but I can say wholeheartedly that I've already paid for the machine, even not aggressively charging for it. So we only charge about 300 to 500 more than we would charge for a full set of dental x-rays. We do not charge extra if we take x-rays on top of the cone beam. The more cone beams we take, the less I feel the need to take x-rays on top of it, but certainly I do when I have any questions, and sometimes have both of the images. We really use it on almost all of our brachycephalics. We use it obviously on all of our trauma, our tumors, and then selectively in all of our other cases. But it has become a mainstay of my practice. And, you know, Steve knows it went down for a little bit recently, and I felt like I couldn't even come into work. So I've become fairly attached to it. But, you know, certainly I'm not selling the machine. I just, you know, am you know, hopefully pointing out the beauty of having something that tells us more about pathology in our patients, which always, you know, treating and correcting that pathology leads to better lives for our patients. So that's why we're here. So that concludes my presentation. Any questions? I guess we'll talk later, but I am going to pass over the screen to John, or I guess Steve, you're going to pass over the screen.
Yeah, I think I can. I think I can do that. Thank you, Dr. Bulow. I appreciate that. You're not supposed to tell people the machine goes down, though. That never happens.
Oh, never, never. It always works perfectly.
All right.
Okay, Dr. Lewis, I think I made. Yep, there you go.
Okay. All right. Can you see my screen?
Yes, sir.
Okay. All right. Very, very nice presentation, Mary. Mary and Steve and I did a little dry run of this recently, and when she told me she had a case of a dog that was shot with an arrow, it brought back memories of my residency. So I'm going to show you a quick case of a shot by arrow dog too. The similarities are remarkable, but basically, some of you who know me, I was in general practice for 5 years, and then I went back for a residency at Penn, and then I stayed there for 11 years, and then went out into specialty practice for 5 years, and then last year we opened up a practice here in Chadds Ford. So upstairs we have the specialty practice in dentistry, and downstairs on the weekends we do some teaching at Silo Academy. So that's where I am right now, and the Silo Academy has been a little bit slowed down by COVID in terms of events that are in person. So when Steve brought up the possibility of doing a little webinar online, I was all for it, and I hope this answers a lot of your questions about cone beam CT. So let me start with Alice. This is Alice. This was a case that I had seen when I was a resident back in 2003, and Alice had this wound that she presented through the emergency service, and the dentistry service at Penn accepted pickups not only during the weekdays but also on weekends, and I was on duty on a weekend, and I came in on a Saturday for picking up Alice's case. She had this wound on the bridge of her nose. She came to our service because she also had a slight shift of the jaw to the right side. And so you can see she's got the wound. The white stuff is some sulfur sulfaziazine that the primary care vet slathered on there before sending it over. And you can see she's also looking like she's blind in the right eye there, as evidenced by the dilated pupil. And she was not visual in that eye on menace response. Basically, the awake exam included findings of some dried blood around the right nostril and a slight shift of the mandible to the right side. And when I went to open the mouth, she immediately showed some signs of pain. So we didn't push it, and we just decided to go ahead and put her under anesthesia, get an anesthetized oral exam, and some dental radiographs. So the anesthesia staff went ahead and put her under anesthesia down in radiology for us. And we could see a lot of swelling in the back of the mouth there on the right side. So we suspected perhaps a jaw fracture. So they did some skull films, and we used to use Nextels. Do you remember Nextels? We used to use those back in the day to communicate. So I received a Nextel with the little Dr. Lewis, and I said yes, and they said you need to come down to radiology to see this X-ray. And so I went down to radiology. This kind of dates us. This was before digital radiography, so there were actually those plastic films that you used to have to put up on the wall. And so they put it up on the wall, and this is what what they found. And so so in this case, it was not just about 3 inches of the metal tip in the blades, but also about 3 additional inches of fiberglass shaft, where I guess maybe Alice got shot. She rolled over, broke off the rest of the arrow right below the level of the skin. And you can see this is pretty far in there. And you can see it's kind of lodged at the level of the right TMJ area. So the diagnosis was made off of skull films, but the CT, and back in 2003, this was a conventional CT, so I don't have a 3D reconstruction for you, but the CT was very helpful to see that there was indeed a condylar process fracture of the right mandibular condyle, and to see that one of these blades was really close to where the neurovascular bundle of the inferior alveolar sits. So we knew we had to be real careful in getting this out. And so when we shaved her up, you can see the entry site on the bridge of the nose there. And then we decided that it was just too far in there to be able to try and pull out, even though we could see the shaft of the fiberglass at the entry site. So we decided to go ahead and go through the neck. And so we prepped her up, and slow dissection, like Mary had mentioned, just kind of going very slow, gently trying to tease things out, getting access to the blades, cutting off the blades one by one as best we could. And then once we got the tip exposed, we were able to attach a Jacobs chuck onto the tip and kind of gently try and tease that out over time. And so here's the piece that came out about 6 inches long. And you can see there's one blade that came off on impact that was hidden in a lot of the swelling. So we were unable to get that out. So we decided to just let the swelling go down and then do a second surgery in the future to take that out. So I think approximately 6 weeks later, we went ahead and put her back under and got the extra barb out. And she went on to do well. Here's a picture of her in the Philadelphia Inquirer, and she even regained sight on that right eye. So it must have been a transient optic neuritis that she had there. But the take-home points from this case are basically our patients are amazing, and they can deal with stuff a lot better than we can. They're my idols. And another good point was don't force it on the awake exam. I think if I had tried to get a better look as to what was going on in the awake exam, it may have been a severe bleed all of a sudden with how close that blade was to some of the vessels. So just a good reminder to to not try to force an awake exam on a reluctant patient. And CT in this case wasn't required for a diagnosis, but it gave us potentially life-saving perspective on where those blades were located. So very interesting set of arrow cases that you probably won't see very often, but the similarities were really impressive. So the next case I'm going to talk about is Bear. Bear is a 7-year-old Labrador mix that had presented for a papillary squamous cell carcinoma. You can see that we have kind of a diffuse swelling in the area of the right rostral maxilla. And here's what it looks like clinically, the papillary squamous cell carcinomas often have this kind of verrucous, lumpy, bumpy type of appearance to them, and this was readily bleeding, and you can see from this view, it is causing some changes to the adjacent gingiva between the second and third incisors, in addition to the diastema between the third incisor and the canine. And so an interesting kind of comparison would be, how does this look with a, say, a size 2 dental radiograph versus a size 4 dental radiograph versus a cone beam CT? And so here's what you would probably get with a well-placed size 2 sensor. So you can see that there's some evidence of some lysis of the bone in the diastema, and perhaps some sclerosis of the bone on the palatal surface of 104, and perhaps some widening of the periodontal ligament space. And if you compare that to a size 4 film, here's what you can see on the size 4 film. And now that you can compare the periodontal ligament space of the 204 on the palatal surface of 204, you can see it does look like there's something going on with the widening of the periodontal ligament space of 104. So that definitely is something that made us want to go ahead and do a cone beam CT. And that's something for maxillary masses, I like to do a cone beam for all of my maxillary masses, because sometimes they can be a tip of the iceberg. And mandibular masses, sometimes with the rostral mandibular masses, I'll just rely on my size 4 dental films. But for the caudal mandibular masses and any type of maxillary mass, I like to do a cone beam CT. And so we use the cone beam CT to get a better feel for extension into the nasal passage. And I think that's one of the biggest things. As Steve said, this is not the ideal modality for looking at soft tissue, but it does show when there's changes in the nasal passage due to extension of soft tissue into the nasal passage from an oral tumor. And you can see that here on the right maxillary canine, which is on our left side. You can see that thickening of the soft tissue in that area that we thought we saw a widened periodontal ligament space on the dental radiograph. So that was helpful for us to kind of think about the fact that this thing seems to be migrating along the periodontal ligament space. So we took margins accordingly to try and get clean margins. And so in terms of the piece that was taken out, this is what we decided upon based on the imaging. So whenever I take a piece of maxilla or mandible out, I like to do what I call a poor man's margins check, where basically I'll take a dental radiograph of the piece just to see if I feel like I'm comfortable with the bony margins that we obtained. And so here's that margin check with a size 4 film. And you can see it looks like we're in good shape, not only in the area where we see the lysis, but also getting far enough up beyond the apex where the periodontal ligament space may have been affected by the papillary squamous cell carcinoma. I think we went through the furcation of tooth number 106 in this case, and then took out the distal root before closure. So interestingly, you can see that the periodontal ligament space does not look as wide on this view. So if my initial x-ray wasn't partially obliqued, then I might not have seen that widening of the periodontal ligament space on the intraoral radiograph. So here's a comparison. There's that intraoral radiograph again that was slightly obliqued, and you can see the change in the periodontal ligament space. But then if you go back to the excised piece, it's not as obvious there. And then here's just a lateral view to kind of assess the bony margins in the dorsal direction. And so we felt comfortable with that. Margins came back as, on the caudal aspect, greater than 20 millimeters, which I was surprised about. I bet that if they looked a little bit closer on the palatal surface of 104 in the periodontal ligament space, they'd probably report shorter margins than 20 millimeters. And that makes me think about, maybe there might be a place for a research project that looks at using a CBCT in comparison to histologic margins and seeing how things pan out in terms of what the findings of the CBCT of the excised piece versus histologic margins versus clinical outcome and chances of recurrence would be. So I think there's a lot of studies that can be done with CBCT. So those of you who have a cone beam and a resident, or if you're in a position to be able to do some of this research, I think there's a lot of low-hanging fruit in that regard that, as Steve had mentioned, there's not a lot out in the literature right now. There is one study that was recently published in the Journal of Veterinary Dentistry that talked about micro CT for assessment of a dog with, I believe it was a fibrosarcoma. And it was just a single case. And they said the results were somewhat clinically ambiguous, but I think that the larger studies might be interesting to look at comparing CT modalities to histologic margins. And that may affect our our rules of thumb in terms of how wide of margins we take, because if you're using a diagnostic tool that is more sensitive, then you might not have to err on the side of taking such wide margins if you are better able to predict based on your diagnostics where the tumor is and where it isn't. So here's the closure of that site, and here's what she looks like post-op, a little bit dished in that area. And you can see we did a crown reduction of the right mandibular canine tooth so that it wouldn't poke into the surgery site while it was healing. And so if that lip fell inward, that the upper lip wouldn't get traumatized from the canine tooth. So the take-home points from Baer's procedure was that the CBCT was helpful for assessment of the bony invasion of tumors. Lots of possible studies that are out there that can be done in the realm of oral surgical oncology. And as Steve had mentioned, CBCT has not been yet validated for use with iodinated contrast agents. I do use contrast agent for a lot of the cone beam CTs I do. I think it helps me get a better look at the lymph nodes in the neck, but I think it's important to be able to take the CBCT as soon as you're done injecting the contrast in through the catheter. The sooner the better after that, and it'll show up better. You'll be able to see the vessels light up too. All right, my last case today is Bocce. Bocce's a 5.5-month-old golden doodle who we saw this summer. He had a presentation that was difficulty sleeping at night and snoring that he hadn't previously done. And so he had been evaluated by his primary care vet, and intraorally you can see that he's got this kind of fluctuant in some areas and hard in other areas, swelling in the area where there is a missing tooth number 104. And so immediately, of course, we're starting to think of the possibility of some type of odontogenic cyst, such as a dentigerous cyst, due to an unerupted canine tooth. Here's another view of it here. And so the plan was to go ahead and put him under, get a cone beam CT, and go ahead and surgically explore this area based on the findings of the CT. Here's some skull films that were done at the primary care vet, and you can see how very difficult to make sense of the dorsoventral view because of having to kind of interpret through the superimposed mandible, but through a intraoral skull film with the mouth open, or not intraoral, but a mouth open view, you can see that we've got the ability to see that there is indeed a right maxillary canine there that's hiding in the nasal passage somewhere. And then the lateral view, you can see that it's very dorsally placed and very caudal from where the contralateral canine would be. So let me go ahead and show you the cone beam CT scan on Bocce. So let's see. Here we go. All right. So we've got, as Steve and Mary had mentioned, there's the the 3 planes that we're talking about. the axial plane, which is often the most helpful for me, which is basically starting from rostral to caudal, the coronal plane, which is basically starting from the top of the head down through from dorsal to ventral, and then the sagittal plane, which is basically starting from lateral all the way through midline to the other lateral. And so these views are very helpful for us to be able to go ahead and take a close look at things and kind of go through the slices, starting from the tip of the nose and then just working our way through. We start to see a cystic structure with some mineralization, and as we go through, we start to see the unerupted canine tooth and then more mineralization that may have been the cause of the inability of this canine tooth to erupt. You can see what looks like the potential for an odontoma that might have been blocking the normal eruption of 104. And sure enough, that's what it ended up being in this case. But you can see how far dorsal the canine is. It's pretty much right underneath the bone of the dorsal nose. And you can see how far caudal this goes. And you can see the cyst continues all the way back to the choana, all the way back to here. And so we knew it was going to be a very challenging thing to be able to get the entire cystic lining out. So you can also take a look at that cystic lining and the caudalmost aspect on the coronal view, and you can see this little outpouching of cystic lining that was just poking through the choana there. But I think one of the things that's really helpful as a surgeon is to be able to kind of have a visualization of what things are supposed to look like when you get in there, right? Because the anatomy is going to be out the window in these cases because of the changes due to the pathology. So the 3D reconstruction, which is really nice, where you can get 3D reconstructions with a conventional CT scanner, but it's not something that you and I get immediately as soon as the scan is over. I used to have to bug our radiologists to be able to create a 3D reconstruction, which is a lot of work for them to be able to do. So it would take some time, whereas this is just generated as soon as the image is taken within that couple of minutes of taking it. And so nice thing we can do with this three-dimensional reconstruction is we can move it in different directions. We can take a look from different angles, and we can go ahead and actually kind of slice through it and look at the bony structures, but we can also kind of change the sensitivity and the density of the structures. So you can kind of see the soft tissues here if I use this slider, and then we can kind of focus more on the bony structures here. And you know, depending on how much you slide it over, you can make everything but the most dense structures go away. But basically, let's find a window here where we can see mostly just bone. So there we go. Okay, so now I'm going to kind of, like I did with the axial slices, I'm going to slice through this 3D structure where I'll just hold down the right button on my mouse, and I'm just going to kind of work my way through and just kind of slice and open things up and kind of get a view as to what's going on here. And then if I let off, then you'll start to see the detail. And there we go. I'm going to go in a little bit deeper there. And you can see this bony or tooth-like structure that turned out to be a compound odontoma. And there's the canine tooth above it. So one or both of these structures resulted in a dentigerous cyst that we made a large window to gain access to, and that allowed us to visualize it, and it just makes your job much easier to be able to remove a lot of the guesswork associated with the surgery. So here we are opening up a large flap. We're going to sacrifice some of these teeth to be able to get more access. So I think we ended up taking out P1, P2, P3, and maybe even P4 to get a nice big window in the bone that we can try and get this entire cyst out. Here's the odontoma. It was diagnosed via pathology as a compound odontoma. And then once we got that out, then we found the canine and took that out. Now, this is a very bloody surgery, as you can imagine. You can see this is something that having a blood product on hand is an important thing. And in this case, Bocce did benefit from a transfusion during the procedure. Here's that little bit of outpouching of cyst that was on the caudalmost portion of the cyst. So you can see we were able to get all the way back there to the choana from this intraoral approach here. And then we went ahead and closed things up. And he went on to do well. He's no longer snoring or having difficulty sleeping. And so that was a real interesting, case, and where the 3D reconstruction really helped. Take home points, that 3D ability of the cone beam and kind of the immediate access to the 3D is really nice. And with the odontogenic cysts, complete removal is important when you can accomplish that to try and prevent recurrence. Some other things we didn't talk about tonight, but I think this cone beam CT is very helpful for is jaw fractures, just so you can see the degree of comminution and see how best to put things back together, as well as TMJ ankylosis and pseudoankylosis. We see a lot of cats who are younger cats that had some type of trauma early in life. They develop a callus in the caudal mandible, between the caudal mandible and the zygomatic arch, and sometimes between the coronoid process. And being able to see what that looks like before you go in is priceless. And so it just makes our job so much easier to be able to visualize that. And then mandibular reconstructions. The nice thing about cone beam CT is you can send your cone beam CT to have a 3D printed version of the mandibular defect, and then you can kind of create a custom bent plate ahead of time to be able to span that defect. So it saves a lot of intraoperative time and worry during the surgery if you can do that ahead of time. So there's a lot of different possibilities with the cone beam CT and the 3D capabilities. And with that, I will say thank you. And I think Steve's going to take over here and we'll do a little question answer session.
Yeah, I mean, if somebody's got a question for any of us, the doctors primarily, please just unmute yourself and go ahead and ask the question. If you got something about the systems or other things, I'd be happy to answer those questions as well. Nobody?
Well, Steve, I guess one thing that I didn't mention that I think it was good that Mary mentioned was, what my normal routine is for use right now. I haven't gotten into offering the, this cone beam CT to every perio case, and I haven't used it much for rechecking endodontic cases. But now that I've seen some of these presentations, like Mary's and Stephanie Goldschmidt's, and Boaz Arzi's at the Dental Forum, I think that I'm going to start using it more and offering it more. Right now our price point's a little bit high, but I think there's different ways to be able to get it to pay for itself each month. And if we're doing more of them, then we might not have to charge as much per CT.
Well, the key that I've always said, Dr. Lewis, is, you earn your money, and the reason you come to work each day is to provide the services to your patients. And that's by finding those things and being more confident and being able to sell your treatment planning options and go into those with that much more confidence is, that's the real payment on these pieces of equipment. Sure, the money you get for pressing the button is important as well, but the ability to do those additional procedures and other things more confidently is a big part of that as well. Somebody had their hand up there. They wanted to ask a question. Yeah, go ahead.
So a little of this answer, I think, but so how are you guys sedating your patients for the company? Obviously, general anesthesia would be preferred, but are you able to use like dextromethorphan, I think you mentioned, to do maybe surgical planning to make it not so expensive, to maybe use it for an upfront planning type procedure?
That's what what I do. I use sedation to make it cheaper for the preoperative planning, so that it doesn't become price limiting for people. So a lot I use dextromethorphan, but I also will use, honestly, I'll just, if it's a really good dog, I'll put an IV in and do Valium and propofol, or I mean, it only takes a minute or two to get the scan. So honestly, usually you're waiting for the patient to wake up. So I do a lot of sedation for my scans. And to be honest with you, I do a lot of sedations even before anesthesia. I don't always intubate them if I'm moving them downstairs to our surgery suite. So the brachycephalics always get intubated. That's the caveat there.
Yeah, same here. It varies from patient to patient, depending on what their conditions are, but our anesthesiologist doesn't hesitate to sedate for the preoperative CT scan, even if the procedure is happening on the same day, where they'll just basically do a O2 mask while they're in the CT scanner. And then once, those, literally each scan only takes a minute or two, even if you're doing multiple segments of, about 8 centimeters or so of scanning, then it really doesn't take very long to get them out of the CT scanner and intubated and under general. So a lot of times we'll do it under sedation as well. The only caveat to that is also that a motion artifact is more sensitive on a cone beam than it would be a regular CT. So it's important to make sure they're sedate enough that they don't move.
Good point.
Yeah, that is a good point, Dr. Lewis. Remember how I said that a cone beam image is a series of individual radiographs, and if there's any movement during that capture, the reconstruction has a hard time going together because it's looking for points that are similar to be able to, to create and reconstruct those images. And if you've got movement in there, it can't put those things together as well, and it creates images that are muddy and poorly detailed and otherwise. The Verity does have a technology that Planmeca on the human side developed called CALM, which is a algorithm that they use that is actually able to account for some minor movement during capture. And in fact, on the human side, they have a video out there now where there's a patient actually in the cone beam, and that human patient has active Parkinson's tremors, and they're able to still get a cone beam image on that patient. So movement is critical, but there are things that can help with that will still yield a diagnostic image. Anybody else have any other questions? You've been more than generous with your time. Dr. Lewis and Dr. Bulow, I thank you very, very much for your presentations and the efforts that you put forth to put this evening together. Is anybody else? We've certainly gone over our 1 hour of time, but if anybody else has any questions, please speak now or forever hold your peace. Well, thank you. I hope you all have a wonderful last month of this wonderful year 2020. And we all look forward to 2021, I'm sure.
Thank you.
Have a great holiday
Steve.
season. And thank you very much.
Thank you, Steve, for helping set this up. Take care, everybody. Have a good evening.
You're very welcome.
Bye-bye.
Bye.